Hello, everyone. Thank you for joining me for this presentation on a topic that has been very important for the research that we've done at the National Acoustic Laboratories over the past several years, and I think it's going to be very important for the hearing healthcare field going forward. And I'd like to thank Phonak for giving me the opportunity to speaking to all of you today. So you can see the topic here. I'm going to be talking about how do you approach hearing healthcare for people who present with essentially no measurable hearing loss, but with hearing difficulties. So let me start by asking a question for maybe all of you to just think about, since I can't see you raising your hands. You're going to see several audiograms. I'm going to ask you to pick the lowest number for an audiogram that you would feel comfortable fitting a hearing aid to. So I've asked this question of hundreds of, probably actually thousands of audiologists around the world. And here's what I overwhelmingly get everywhere. If I asked anyone if anyone would fit a hearing aid to someone with audiogram number 1, basically no one raises their hand. If I asked about number 2, I might get 3 or 4 people in an audience of 1,000 raising their hands, and that's about it. And it's really audiogram 3 and lower where pretty much everyone raises their hand. They feel that yes, they would be comfortable and feel it's the right thing to do to fit a hearing aid for someone with that audiogram. And it's that thinking that I hopefully will try to change for this presentation today. So there's 2 key questions that I want to answer in this presentation. One is, do people who have minimal hearing loss, as measured by the audiogram, need hearing help? So is it even a problem that we should be thinking about? And secondly, if the answer to that is yes, can they benefit from hearing devices? Which sort of speaks to, okay, if they need help, how do we treat them? And typically how we treat hearing loss is the provision of hearing devices, hearing aids. And so that is probably what our first reaction would be to someone with who needs hearing help with minimal hearing loss. But it begs a lot of questions about how do you fit the hearing aid and so on. Would they even like it? Do they want it? Would they benefit from it? So let's start with that first question. Is it the case that someone who has no measurable hearing loss actually could have a need for hearing help? Well, let's start by looking at the World Health Organization's classification of functioning, disability, and health. So they say that someone's ability or disability should be measured by the functions of their body, their anatomy and structures, what their daily activities are and how they're able to participate in the world around them. They also add that these factors can be modified by the world around you and by individual factors that don't really have anything to do with the function of the structure that's at hand. Now, if you think about an audiogram, we're only addressing that first point, the function and the structure of the cochlea. Can sound get through? Can you detect a pure tone at a specific frequency at a normal level or not? And that typically is mediated by function or dysfunction in the cochlea. But this statement here, which applies to all aspects of health, not just hearing, says there are other things that should be considered when one is considering whether someone has a disability that is health related. And if you look specifically at the World Report on Hearing that WHO issued a few years ago now, this is a direct quote from in there, where they say that hearing thresholds, i.e. the audiogram, should not be used as the sole determinant to assess disability or to determine whether you should provide someone with a hearing aid or with a cochlear implant. Now, this is pretty shocking, I think, to anyone in the hearing world, because this is exactly what everyone does worldwide. Someone walks into a clinic, the audiogram is taken based on the amount of hearing loss. The audiologist or hearing care provider will then make a determination on whether that person has enough of a problem that requires a solution, and then we'll make a decision on whether they should fit them with a hearing aid or not based on the audiogram. This is exactly what WHO says you shouldn't be doing. Well, so who else has sort of been aligned with this? Well, actually a lot of people. So again, a few years ago, the very influential U.S. Preventative Services Task Force, which looks at how can, on a large scale, national scale, can you prevent disease states in the population for the benefit of society, looked at whether it would be valuable to have hearing screening for older adults, people 50 years or older. And their conclusion, again, sort of a surprise to people in the field at the time, was no. They did not recommend that if you were over the age of 50, you should get, just as a matter of regular practice, a hearing screener. It's not that they didn't believe hearing health is important. What they believed and what they found from literature survey is that there is little evidence that the amount of hearing loss, which is what a screener measures, a simplified version of an audiogram typically, has much of an ability of indicating whether someone has a need for hearing help or whether they would benefit from hearing devices if you provided for them. So they're not saying hearing health is important. They're saying measuring someone's thresholds is not a great way of telling whether you should be helping them, and therefore they don't recommend screening adults in this way. But we've known this for a very long time as a field. This is from a long time ago, 35 years ago, published from the Framingham epidemiological study showing that 20% of people who said that they had a hearing loss actually had normal audiograms, showing a disconnect between perceived hearing loss and whether you actually have one. And this is correlated with our findings. We're associated with about 185 hearing clinics across Australia. And something like 30% of the people who come to us for hearing help, we measure the hearing and they have normal thresholds, i.e. pure tone average below 25 dB PTA. And so guess what we do is say, congratulations, you have normal hearing. No need for our services, come back in 5 years and we'll test you again. So, but 1 in 5 of people who think they have a problem, we know have normal hearing, normal audiograms, and it kind of begs the question, well, what is the problem? They have a problem, how can we help them? And how can we get over the hurdle of using the audiogram as a way of determining whether they have a need or not? On the flip side of that data, another epidemiological study found that almost half of the population with people who actually had what we would define as a measurable hearing loss, almost half reported that they had good hearing. And so 43%, so over half, so about half of the people who have a measurable hearing loss, who audiologists, hearing care providers would try to convince to get a hearing aid, saying you have a hearing need, actually don't have a hearing need. They're doing just fine. They think their hearing is fine, so good luck convincing them that they should buy a hearing aid or they should wear a hearing aid if they don't think they have any hearing problems. And again, we see that in our clinics as well. Something about perhaps 60% of the people that we see who have a measurable hearing loss end up not getting a hearing aid, even though here in Australia, you can get hearing aids for free. And so this speaks to basically sort of the classic consumer approach. You can't sell something to people, something that they don't have a need for. And so it's something that we kind of ignore in the hearing healthcare, the user need. We just focus on the diagnostic, and then we assume we understand their need based on that measure. Well, how about just asking them whether they have hearing problems or not? So I looked at this a few years ago, and what is the population of this group who have hearing problems but have normal audiograms? So this is a schematic showing sort of the whole population who people who have some sort of hearing dysfunction, and you can split them either between they have a measurable hearing loss or they don't have a measurable hearing loss, or they have no reported hearing difficulty, or they do report that they have hearing difficulty. Now, the traditional patient or client for hearing healthcare worldwide is this group here, the group who not only believe they have hearing difficulty, but they have a measurable hearing loss. And that's who we do a really good job of fitting with hearing aids. Although there are still people sitting on the sidelines for a variety of reasons, that's beyond the scope of this presentation. However, besides that, I want to focus on this group of people here. Now, these numbers are US numbers. So according to my estimate, there's over 25 million people in the United States, adults, who don't have a measurable hearing loss, but have significant complaints about their hearing and probably would be open to a solution if it were offered to them, which we are currently not doing. Now, just again, to put the nail in the coffin of the audiogram here as the arbiter of whether someone has the hearing need, there was this paper a few years ago just calling out the fact that this 25 dB level for pure tone average is rather arbitrary and where we make decisions on whether someone has a hearing loss or not. And again, a quote from this paper that the audiogram alone cannot adequately predict the impact of an individual's hearing loss. Now, we all intuitively know this because anyone who's been in our field knows that two people with the same audiogram can respond very differently to hearing treatment, and also can have very different experiences unaided and significant differences in their ability to manage unaided. So we know the audiogram isn't a great indicator of how someone is doing unaided and how someone will do with hearing aids, yet we continue to pretend that it does, because I think because we don't know how to do anything else, and we certainly don't know how to treat someone not based on the audiogram. So Larry Humes took a swing at this a while ago. His approach was really thinking about, well, in the OTC world, if someone isn't seeing an audiologist, how can they tell if they should be getting an OTC hearing aid? So he's trying to find a replacement, a substitute for the audiogram, which is not how I'm going to use his thinking, but it's the starting point. So what his recommendation was, if you use the 10 question hearing handicap inventory for the elderly screening test, that could be a replacement for the audiogram in terms of determining whether someone should get an OTC hearing aid. The HHIES is really simple. 10 questions that you see here. It's the kind of questions that an audiologist or hearing care practitioner would ask a patient coming in. Does your hearing give you a problem talking to your friends? Does the hearing give you a problem listening to understanding on the TV, and so on? And you score it really simply. The responses are either never, sometimes, or always. And you get a score between 0 and 40, where higher is worse. So this is data that Larry pulled out of 10,000 participants, where he had data on both the audiogram and the HHIES score to show that there's a correlation between the two, and the HHIES could reasonably replace the audiogram if it had to. So, in our world, we consider this yellow line here, the 25 dB mark in pure tone average, to be the cutoff, where to the left of that, we say you have a hearing loss, and to the right of that, we say you don't, and you don't need care. Larry suggests that we take a score of about 10 for the HHIES. And if you score worse than 10, then you have a hearing problem and should get help. If you score lower than 10, you don't have a hearing problem, you don't need help. So if we consider the two of these together, we look at those who score poorly on the HHIES, those who have a poor audiogram. Yes, indeed, there's a large number of people who score poorly on both. And so one can kind of replace the other for this group. However, there is a group of people who have hearing loss, pure tone average is above 25, but they have very good scores in the HHIES. They are not indicating that they have any problems at all with hearing in their lives. And again, good luck trying to convince this population that they need a hearing aid. You're wasting your time. And even if you give them a hearing aid for free, as you can here in England and others, they probably won't use it because it's not affecting their life. They don't have a need. And what I want to focus on is this group of people who are being left untouched. They're being underserved. They have significant difficulty in their lives from their hearing, but because as you can see from those quite high scores on the HHIE, but because their pure tone average is less than 25, we are not treating them. In fact, we're ignoring them, and we're not confirming that they have any problems. In fact, sometimes we tell them they don't when they know they do. So hopefully I have convinced you at this point that the audiogram is not a great indicator of whether someone has hearing difficulty or whether we should be treating them with hearing solutions. And that there are a large number of people out there who have what, again, we call normal hearing, minimal hearing loss, but have hearing difficulty, and we should be considering how can we help them. So that begs the next question. How can we help them? If we decide, yes, indeed, this person has a problem, I want to help them. Well, can we do sort of our first approach to helping people with hearing loss and fit them with hearing devices. I think a lot of people out there would, for a long time, have said no. A lot of people, have said if someone doesn't have a hearing loss, they can't benefit from a hearing aid. In fact, it might be unethical to fit them with a hearing aid. And I've talked to audiologists who have that very strong point of view. Again, let's see what we have found in our research at NAL. So we did a study a few years ago where we looked at, we recruited people who had no hearing loss, minimal hearing loss, but had significant complaints of understanding speech and noise. And then we recruited them, we fit them with hearing aids, and we did laboratory and real world measures of benefit with these two groups, including self-perceived benefit. So we had two groups, 15 people each. The control group were fit with hearing aids. These were high-end Phonak hearing aids, both of them. But in the first group, we turned off all the speech and noise features, no beamforming, no noise reduction, and we gave them 0 dB insertion gain. So it was still on, you can still hear the mic noise, but really they should be getting no benefit from it. But we didn't tell them that that was the case with their devices. We told them that they should be benefiting. The experimental group, they got the full-on treatment. The hearing aids, had gain. The hearing aids had noise reduction, beamforming, directional microphones, all of that to try to give them the full benefit in noise. So these are the average audiograms of the people that we recruited. I think you can pretty safely say if any one of these people walked into a hearing clinic, they would not be given any treatment whatsoever and would be told to get lost in a nice way. So we've got a ton of data on the result of this experiment, which we published. I'll give you just a couple of the highlights here that I think kind of get to the heart of it. We have a variety of questions on what their experience was with their hearing aids. And again, control group got no benefit. We're hoping that they would score poorly and that the experimental group would score well. If you look at, say, these two questions, are you convinced that obtaining your hearing aids was in your best interest? Control group, this is a scale from, I think, 1 to 5. So they basically said no on this question. Whereas the experimental group, were 3.7, that's pretty high. So they felt that they were getting benefit from their hearing aids. Look at the other question. Do you think your hearing aids are worth the trouble? Again, I think a lot of us going into this would think, boy, if you have normal hearing, there's no way someone's going to go to the trouble of wearing a hearing aid, taking it off, replacing the batteries, charging it, putting it on their ear, the itchiness and all that. Again, control group basically said it's not worth the trouble. Experimental group said absolutely it was. For me, the bottom line was we had so after the laboratory testing, they wore these devices at home, wherever they wanted for 6 weeks. After 6 weeks, they came back, we did more tests, and then they had to return the hearing aids. So we asked them at that point, would you like to continue to wear these hearing aids now that the study is over? Again, in the control group, basically everyone said no way. Didn't provide any benefit, couldn't understand conversations, wasn't good enough. But about 65% of the people in the experimental group actually said yes. Said yes, they would want to continue to wear their hearing aids. And when we asked why, basically they said because they were helping me in specific situations. Not all the time. They don't have audibility issues, they have speech and noise issues. And these hearing aids were helping them with speech and noise. So it was doing what they were intended to do. It was addressing the unmet need that these people had. And these people with normal audiograms wanted to keep wearing hearing aids. Something that I think without this data, no one would really ever believe. And so this gave us a very strong indication that hearing aids, particularly those with good speech and noise improvement features, can benefit this population because their number one problem, possibly their only problem, is problems with understanding, listening fatigue with speech and noise. And so that got us on a whole track of more research that I won't get into. But we did take a look at, right around that time, Apple started coming out with hearing aid-like features in their EarPods. Now they are actually hearing aids with FDA-approved hearing aid technology. But while it was still hearing aid-like, but before actual hearing aids, we did a study, very similar study to the one I just talked to you. But now people are wearing AirPods instead of hearing aids, in part because a lot of people in the world were saying, God, hearing aids are terrible. No one wants them. But if Apple comes out with hearing aid features, everyone will wear them and everyone will benefit. So here it was, Apple had done it. We wanted to test whether this was in fact true. So we basically ran the same study. We recruited people with normal audiograms and abnormal speech and noise difficulties. Here's their audiograms. This time there were 17 participants. And we ran the same protocol, fit them with the AirPods, laboratory measures. They wore them in the real world for 6 weeks, got a variety of measures out in the field and back again. Again, I'll only show you a sampling of the data here. The saddle is a pretty common way of measuring benefit from hearing aids. So we applied that here. And it's a score that goes from 1 to 7. When the saddle first came out in the year 2000, I think, the average hearing aid back then scored about a 5.5. So hearing aids, 25 years ago, were scoring, again, 5 or so. AirPods, you can see here, scored 3.5, 3.3. Higher is better. So that tells me, according to the standard approach, people didn't really believe that they were getting a benefit or were satisfied with their AirPods, even compared to very old hearing aid technology, let alone how hearing aids would score on the saddle today. And again, that bottom line question at the end of the study, after 6 weeks of wear, we asked them, study's over, do you want to continue to wear your AirPods to help you with, your speech and noise problems? Almost everyone said no. And the reasons were, a lot of it was stigma. Some of it was they just didn't hear the benefit, but a lot of it was there is benefit, but there's no way I'm going to wear these devices in a social situation. It was uncomfortable, it was embarrassing, everything you might expect if someone's at a restaurant or at a party wearing AirPods, which of course traditional hearing aids like Rick's solve because you can't see them. And so stigma really kind of goes away in those kind of situations, which again flips the story on its head of how we think about hearing aids and stigma. Of those who said yes, there were 5 out of the 17. Even they said, you know what, it is still stigmatizing and it's uncomfortable wearing them socially. But as long as I was in a situation where I could explain why I was wearing the AirPods, like small family gatherings, then it was fine. And then I got benefit. But it couldn't have been in a general environment where they were having difficulty. It had to be these small situations with trusted friends and family who would understand why they're doing what they're doing. So hopefully at this point, I've convinced you that yes, in fact, we can provide solutions for people with minimal hearing loss, but speech and noise difficulty. And in fact, hearing aids can benefit them, and so far are probably the de facto best in class in terms of technology that you can use to help someone. And we shouldn't be trying these hearables and AirPods and Google Pixel Buds or whatever is out there right now, because they aren't as great a solution as hearing aids, of course, as we probably all know. So I want to sort of finish with, okay, so convince me people with minimal loss need help. We can fit them with hearing aids. How do I fit them? How do I fit a hearing aid on someone with no hearing loss? Okay, so that's why we have done what we've done with the latest NAL NL3 prescription, which now we've got the whole presentation on this. We're happy to do at another time. But one component of NL3 now is that we have modules for specific situations where the main prescription isn't a good solution. And so we identified this group of people with minimal hearing loss who need a different approach to a fitting target than the general prescription. And you can see that here. If you look at, take this audiogram, for example, of someone with minimal hearing loss. This is what NAL NL2 provides for a gain target, basically nothing. So right now, if you take the traditional approach to fitting a hearing aid for this group, you get no gain. So our design goal for this module for minimal hearing loss in NL3 is it's got to have enough gain so the amplified sound is above the free field sound coming through the canal. That way the person can get benefit from the speech and noise features, but it can't be too much gain that it's going to be uncomfortable for them, because keep in mind they have normal hearing and they're going to have normal tolerances. So it can't be too loud, especially in noisy environments. So it's a trade-off between these two competing goals. So we've done a lot of studies. Up at a while ago, we had 43. We've got more now participants looking at this. This is the average audiogram of this group, about a 20 dB 4-frequency pure tone average. So just real quickly, here's the data we've gotten so far with this. We've seen in the laboratory that you can indeed get benefit to speech understanding with good hearing aids that have good speech and noise technology. So we've seen up to about 12%. It's going to depend on the product. It's going to depend on how good that speech and noise technology is, the directional microphones, the beamforming. But if they provide good SNR improvement, this group will get speech and noise benefit. We also, when we look at questions in the real world and in the lab, is it too loud for you because you're not used to wearing devices and you have normal hearing? There was no difference between basically the 0 dB gain condition and the condition where we added gain, whether naturalness, comfort, or quality. And then finally, when we asked them in the real world, when they wore these devices out in situations where they are having difficulty, we used our EMA to question them in these situations. The overwhelming majority of them felt that the module was clearer and gave them the least amount of effort when listening to speech in noisy situations compared to the traditional NL3 prescription, which is basically, again, a 0 dB prescription. So doing nothing compared to giving them some gain actually helps in the real world and helps in their perception of the sound as well, improving speech understanding while not making it too loud for them, making it uncomfortable so they can still wear this. So what does that mean for audiologists with this module in NL3? We believe audiologists can now start to fit hearing aids on people with minimal hearing loss, with pure tone averages less than 25, if they say they have hearing difficulties. But you've got to fit patients with the best speech and noise technology that you can. And it kind of begs the question, well, how do I tell whether they're a candidate or not? The audiogram isn't telling me. We recommend using something like the HHIE or the COSI 2.0 that's coming out soon as a way of determining, do you have a need? Do you have speech and noise problems? If you do, even though you're not seeing any measurable hearing loss, we believe you have difficulty enough that we want to test a solution for you. And that's, really great hearing aids with great speech and noise technology using the NL3 minimal hearing loss module. So in summary, again, the key points here, you can have hearing difficulty and need hearing help, even if it doesn't show up in the audiogram. And even if you have minimal hearing loss without any measurable hearing loss, you can still get benefit from hearing aid technology. So if there's one takeaway message, don't just rely on the audiogram in order to understand the needs of your patient or in order to determine what kind of treatment strategy you should be taking for them. So thank you very much for your attention on this. I hope you found that beneficial, and thanks again for your attention.